Welcome to the second part of our NHS West Yorkshire board meeting here in Brighouse. Today we are looking at a number of reports and topics across our West Yorkshire integrated care system. As you know, if you've been watching previously today, we have just talked about acute services and 6 particular trusts working in collaboration together for the benefit of patient services and improving services together. We're now going to come on to some of the more standard reports that we have, including our system performance report, but we will be having particular reports on maternity and neonatal services and also our first annual Freedom to Speak Up Guardian report. So the next item is item 13. It's my report as chair of this board. As colleagues around the table know, this is a report that records good governance taking place, partnership working taking place, and Laura and I together try to make sure that we are recording work that sits against the Care Quality Commission's well-led framework as well. So there's lots of things in there. One thing very relevant to you as board members is in Appendix 1, and I've even got a printout here, is our new cycle of governance from April this year. I wonder, Laura, whether you could summarise in maybe about 60 seconds about our intentions with this cycle.
Thank you. Yes, and I think I reflected on some of this at the last board meeting. So this is about primarily about improving flow of assurance and information through our governance cycle. So by extending the cycle from our current 8 weeks to 12 or 13 weeks, it means that we should get a much better flow of assurance through. So hopefully, I think there is a second appendix, and that tries to demonstrate what that flow looks like on the way through. Thank you.
Okay, and we'll continue to evaluate that as we did. We are a new statutory body, but we all collectively bring a lot of experience in good governance and board practice. So, and thank you to so many people who got together to put that in place. And I know around the table we need to just test that now in practice and feedback on our learning. There are lots of other things in there, including a summary of our latest visits programme, including to colleagues in Locala, and also a climate change visit, which was hosted by Mid Yorkshire. And we're really pleased to get out and about and engage with leaders and services across the partnership, as well as to support them in removing barriers and supporting them with new opportunities and transformation. There's a mention there around the continuation of a new chair and non-executive director development group, which particularly is striving to make sure that we have succession planning on NHS boards and greater diversity in that membership. And then you've also got a variety of information, including on our involvement framework and ways in which members of the public can be engaged in our work as an ICB, an integrated care board, and across our partnership. And lastly, I wanted to welcome Sarah Jones as the new chair of Bradford Teaching Hospitals NHS Foundation Trust. She joined on the 4th of March. She was previously the chair at Sheffield Children's Hospital, and we're really delighted to welcome her to our West Yorkshire partnership. So there's lots of information there, but as you know, I'm aiming to record good governance and lots of things that are going on together in our partnership. I don't know if anyone's got any comments or questions at all, but happy to take some comments or questions. Silence is really helpful because that means we can move on to our next report. But one thing I wanted to share is there is a record there of how many people are viewing both these board meetings online and also our partnership board meetings that we have quarterly, and we will be following that up to gain feedback from people on why they're watching and what they're finding of benefit. I know a lot of staff across health and care watch these meetings to stay up to date, as well as members of the public. I will leave it there if there aren't any other comments. Okay, we're going to move on now to our next item, which is our Deputy Chief Exec's report. I know thanks to Jonathan Webb and to Ian Holmes, who've been deputising for Rob whilst he's been on leave, which is why we've resulted in a Deputy Chief Exec report. So I'm going to hand over to Ian Holmes first, but Rob, please comment as well. But Ian, or are you going to do it the first? You're going to do it that way? Between the three of you. Okay, Rob, to you first.
Yeah, in the interest of time, I think people have got the report, so thanks to Ian and Jonathan for pulling the report together. I just wanted to, given this is a contextual report, really just highlight 3 things. The first is thanks, really, to the 100,000 staff, the 400,000 people who are informal carers, and the approximate 150,000 people who volunteer in West Yorkshire for what they're doing every single day in what are incredibly difficult times. And I don't think we can say thank you enough. Brendan and Wyatt colleagues talked about the 50,000 who work in their institutions, and we can multiply that many times over. And we need to say thank you because of the context that we're operating in. So that's the second thing I wanted to just keep reinforcing. So let's remind ourselves that international conflict is having a direct impact on people in our organisations and our communities. And thanks to Fatima and local authority colleagues around the table for developing good practice guidelines and support for line managers about how we support staff in these times, because it can be quite difficult. So we're in that kind of context where the cost of living crisis, increasing poverty, international issues are directly impacting upon our staff. And we are living through industrial action. So we've had over a year of industrial action now. We've had the latest spate of industrial action since we last met, and we successfully managed it. Now, it would be very easy for us all to think that because we're successfully managing it, it either is easy or doesn't have an impact. Well, it's not easy, and it does have an impact. It has an impact upon staff who consistently have to manage this rather than productivity and improvements in the system. And that has an impact upon the thousands of people who have their procedures postponed. So we've had industrial action, which is continuing, and we've been living through winter. So staff have been dealing with winter pressures across the last few months. And as you can see in the other papers, we've been planning for winter since last March and continue to learn lessons. We've been doing that at the same time that our organisation, the Integrated Care Board, has been restructuring, having conversations with staff about redundancy, making people redundant and asking them to apply for jobs and roles in the organisation. And we've then been asking them to continue to get on with managing industrial action, winter and everything else. At the same time, we've been getting to the end of 2023-24. We're about to get there, aren't we? Again, thank you to everybody in every bit of the system, because we are likely to deliver our financial targets of being in balance. Commentators about the NHS would have suggested that wasn't possible. But we have delivered it, and that again has not been easy or straightforward, and has required a degree of action in all organisations, which has been significant. We've also done pretty well on delivery against a set of revised standards, not the ones in the NHS constitution, which we all want to reach for over the medium term. And again, that's down to our Wyatt colleagues in the Mental Health, Learning Disability and Autism Collaborative, Primary Care Community Collaborative, etc. And we've been asked to plan for 2024-25. All these things are on the agenda today. But if you think about putting all of those things together, 2024-25, in a context where we don't have any planning guidance because of political conversations that continue between the Department, NHS England Treasury and Number 10, then we need to be saying thank you to everybody. If you think about the board conversation we've had so far, in public and in private, I think it's been characterised by a sense of pragmatism, realism, and needing to just get on with it. I don't see people come along with demands, as Brendan described earlier, complaining or whinging about things. What I see is people trying to get on with it. And the third thing I would say about the context is if you look at the report that Ian and Jonathan put together on the rest of the agenda, you can see we're still getting on with pushing things beyond a tightly defined agenda of waiting times, ambulance response, etc., because of things like the adversity, trauma and resilience work that we've just been doing, the work that we're doing on neurodiversity and how we improve things for people in our populations, and how we think about things like poverty being an anchor system and so on. So I think that the people that we work with, the people who work for us and our partners deserve a great deal of thanks for that. And I hope those opening remarks and Ian's report help set the context for the meeting we're about to have.
Thank you very much. Ian and Jonathan, is there anything you'd like to highlight in the report?
Yeah, maybe just two specific things. Thanks, Rob, for the overview. The first one is that we're noting in the report that we're extending the joint working agreement with NHS England around specialised commissioning. So originally we were going to take that in 24, 25. We've pushed that back to 25, 26, which means we'll extend the joint working arrangement for another year. This is a really good example of a piece of work that we're working on a day-to-day basis with our colleagues. It's a real joint endeavour, but that's just for the board to know. I guess the second thing to mention that's quite important in here is that the staff survey results came out between the last meeting and this meeting. We benchmark relatively well against other ICBs. At the same time, our scores have dropped since where they were last year. You may expect that as a result of the process that Rob described that we've been through with staff, but there is variation across the different questions, variation across places and directorates, so we need to understand that and respond to that appropriately. So that'll be a big part of the focus of the executive leadership team over the next couple of months. Just those two things. Thanks.
Thank you. I don't know, Jonathan, we're going to come on later, aren't we, in the integrated performance report and hear further from you. I wondered if you could just, I think I'm always conscious of people watching this meeting that there are concerns over measles in communities at the moment, and I know that we're working as a partnership and with colleagues in NHS England and others. I don't know if you could just give an update for public assurance, Rob?
I don't know if James wants to do that, and maybe we might also get an input from Rachel.
Thank you, James. Then Rachel, would you introduce yourself?
So I'm James Thomas. I'm the Medical Director for the West Yorkshire Integrated Care Board. Yes, measles is extremely topical, has been for many months, I suppose, for assurance purposes, but also to highlight kind of there is some great work that's happening across West Yorkshire, recognising most of the work in terms of both prevention and also response to the outbreaks happens in our communities, so therefore happens in our places, and it's working with the teams in our places. So there's good discussions, there's good action between and working with UCSA, which is the UK Health Security Agency, with our public health colleagues, and Rachel may want to come in places, and across West Yorkshire and NHS England, recognising that our immunisation rates as nationally for MMR are not as good as we'd want. They weren't as good as we wanted before COVID. Things have got worse over the last 10 years, recognising that. So it is about prevention. It's about making sure that we reach the communities that may not take up the MMR. We've also kind of been working with the communities to kind of emphasise that, working with general practice as well, to try and help support the delivery of the vaccines there, and also working with our organisations as well to ensure that our workforce are vaccinated appropriately as well there. So yes, there's a lot of work to be done. There's good focus on it and good partnership working across our places, across the communities and across organisations to help this happen. But there's a lot more work to be done, but I give assurance to the board that is happening.
Thank you. Rachel, would you introduce yourself?
Hi, yes, Rachel Spencer-Henschel, Director of Public Health. I just want to support what James has said and just to say that there's quite a lot of evidence to suggest that actually the barriers to taking up vaccinations is more to do with time and accessibility than any other factor. And actually that maps quite, as you would, consistently with areas of deprivation. And I just think it's important that we remember we are hugely skilled at dealing with this because of what we did during COVID across our system, and actually taking the vaccinations out into those communities can often result in a really high uptake in a short period of time, because it's purely about getting the right time and having the right conversations. So we've got such a skilled workforce in knowing how to get people to take them up. So I think, if we can get the vaccines to people, then we know that uptake is good and we can turn around things quite quickly, which much reduces the risk of outbreaks.
Thank you very much. So that is the report. Does anybody want to ask questions or comments? AC, and then Jane, and then Richard, then Becky. Thank you. AC.
Thanks, Kathy. Just want to pick up on one of the sections around keeping it local, ICS, and that's particular. So again, continuing with the previous conversation about joining things up together, the Power of Communities program was funded last year, I think probably about 1 million to the sector and about 1.8 million to the VCs, the hospices. How would we get back again a feedback in terms of what's working well in that particular space as part of that program, and linked up with some of the conversation we had with Wyatt, primary care and so forth again? Because I think based on the Health and Social Care Act reforms and changes around integration, this is one of the key differentiators we need to build up bottom up. So I think keeping a very close eye on its implementation, success measures and integration is vital. So a request in terms of whenever we have the next VCAC focused session to have a very sort of detailed feedback on how that program has been ongoing for the last 12 months and so forth.
Okay, so some of you will remember that we had a focus on session on the sustainability of the voluntary community and social enterprise sector a year ago, so I think that's something then we can go back and talk to Kim Shuttler as representing the sector and a board member, and Pip, ask you to go back to talk to Kim about that. Ian, this is your area as well, so keep it local. I understand the first stage is bringing in Locality, which is a national not-for-profit, to come and do an assessment with us to work out where we go, is that right?
Yeah, happy to come in, and then Pip might want to come in as well. Yes, so it's working with an organisation called Locality. I think they're working with the majority, if not all, of the local authorities in West Yorkshire already. They've got capacity, expertise, and a structured way of working with partners to help ensure that we're embedding those principles that are described in the document throughout our sort of core way of working, our core business processes. It's absolutely in line with the ambitions that we set out in the board report last year. We see it as providing a bit of extra capacity, a bit of extra expertise, a bit of extra know-how to progress that work faster. With the first ICB in the country doing it, but like I say, they're an organisation and it's a methodology that's pretty well understood across the local authority space.
Yeah, thank you. I mean, the other key thing to say about keeping it local is we already have the 5 places, all of the local authorities signed up. So it's a real opportunity, isn't it, to kind of take that learning and resource that's on offer nationally, but also to make sure that we're sort of joining up with local authority colleagues, which is, you know, again, been one of the themes of today, isn't it, is how do we do things together, because it's together that we're stronger. In terms of that, we have to walk the talk as well, don't we? We have to, you know, make sure that we're saying those things and putting them in place, but that we're also kind of living that out in our experience. But yeah, massively welcome the keeping it local. I think it's a huge opportunity and some really good national resource and expertise that we can draw on. Just very briefly, your question about Power of Communities. We are in the process of evaluating that, and absolutely we you know, it was allocated to each of the 5 places. Slightly different things are happening in each of the 5 places because we have different kind of resource and landscape. But if you know, we will absolutely report back on that. We're seeing some really good evidence of that's reaching really small frontline organisations. We've just heard about measles, and it's often about the messengers, isn't it, as well as the message and the knowing. So it's having that breadth of third sector is absolutely vital, and I think that's a huge you know, the investment that West Yorkshire have made to the third sector is really enormous and much appreciated. But we also know that the rest of the landscape is changing, isn't it? And some of the impact on the third sector, particularly of local authority funding being cut, will have an impact on all of that. But it would be really good to bring that back, wouldn't it? And, you know, as you say, I'll obviously take that back to Kim and to look at how we kind of bring that back to understand all of those different variables. And continue to build on it, because it's only by having that strong, full partnership that we will really achieve everything that we're trying to do together here.
Great, thank you. And I wonder, AC, in your role in chairing Finance, Investment and Performance Committee, it might be something you want to take a more detailed interest in, and then maybe come back to the board in summary on that. Brendan, do you want to respond on that? And then we'll go to other colleagues, Jane, Richard and Becky.
Only very quickly, I think we should be bringing this agenda item in the conversation about social value together. So in and amongst all of this, there is some hope for all of us. You know, there is building, there is capital investment. That's good jobs, good procurement for local businesses and people. We should be bringing these 2 conversations together, I think, whether it's through a board development session or here. But I think we shouldn't have them separately.
And I think this is what we're trying to do as a new statutory body, work out how we are complementing what the Partnership Board has, which has been established for many years. So I think that's something we can take forward. And if Kim was here, she'd say, as she said in the Partnership Board meeting on the 5th of March, is keep it local complements everything councils are already doing, and it also complements the new NHS England provider selection regime. I managed to say that all together. So this is a good thing. Okay, thank you, AC, and I think perhaps something for your committee as well. So then we're going to go to Jane, Richard and Becky.
Thanks, Cathy. Just 2 or 3 things, actually, since I've got in early this time. So, Jane Madeley, I'm a non-exec member. This section on the staff survey was interesting to read, and great that you've provided the link so people can see the sort of detail within that. We talked a lot about staff earlier, Robert, your introductory comments in terms of thanks, etc. So I'm kind of hoping that a summary of the action plan on CMT have kind of approved that. If we could bring that back to the board so we can kind of see where we're focusing, that would be really helpful, rather than just have the results of the survey. So I look forward to seeing that at some point. 2 other things more in the sort of funding environment sort of area. So we put out a partnership statement, didn't we, in terms of local government finance on concerns around the system. So interested to hear if there's been any sort of response, feedback that in the journals or anywhere else. So any response to that would be useful for us to be aware of. And then secondly, thinking about the budget, where obviously, and we put a response to the budget out, thinking about, the big focus in terms of investment in digital transformation, etc. Do we feel, and knowing that the opposition party, if they come into power, have also talked about the need for the NHS to recognise it needs to transform, etc. How do we feel in terms of being equipped to respond to that? I know we have our transformation board, etc., but it'd be good to get a sense of, we probably can't do it justice now, but a sense of how well prepared we are to really take that challenge on, because it's coming at us from various angles now, I would say. Thanks.
Thank you, Jane. That's really helpful. I'm going to ask Kate just to immediately respond on the staff survey action plan and then come back on those other points in a moment once we've heard from colleagues. But Kate, if you could just respond on that point.
Yes, apologies, I nodded. I think we were saying yes. I mean, we're at the stage where EMT colleagues have all got their own detailed surveys for their own areas. They have an HR business partner link. So once we've got that coordinated, a consolidated action plan for the whole of this will be for the ICB itself as an organisation. Happy to share that with you. Yeah, thank you.
We'll come back on those other points in a minute, Jane. Richard, then Becky.
Also 3 brief points. Also on the staff survey as well, this ICB was the first to broaden the staff survey to general practice and primary care this year. I've no idea how many colleagues completed the survey, but as part of that analysis, it would be quite good to look at that, because maybe a year or so ago, we did sort of raise the point about having comparative data between different bits of the workforce, and it'd be good to be able to do that. Just 2 other things that you've raised. One is about industrial action. Colleagues will be aware that general practice hasn't taken industrial action, is one of the few bits of the medical workforce that hasn't. And yet the response from government nationally has been to award the potential of a 1.9% uplift to contracts for next year. That's going to have a material impact on our general practices in the coming year if that doesn't change. So I would encourage the board, if possible, to encourage national bodies to relook at that and to highlight the consequences of that, not least of the fact that general practices have to award those staff who require it sort of the living wage increase, which is significantly higher than a 2% uplift. So it's going to have a material impact on our practices, and really should be maybe part of our risk register in this coming year. And the final point is on vaccinations. It's within the report, and I think we should congratulate practitioners and pharmacists for achieving a 53% uplift, a 53% achievement level for COVID vaccination in this most recent autumn-winter campaign, with care home residents, our most vulnerable patients, 78% achievement. But within that report as well, it does highlight that a number of primary care networks didn't take part this year, and in those areas there was a reduction in the level of uptake, particularly in mobile patients. And again, I would like this ICB to reflect that back to the Department of Health and Social Care, who are considering a national vaccination strategy, which potentially might move some vaccinations away from general practice. And I don't think that would be a really helpful thing for our population, who really do depend on GP practices and pharmacists working together in a positive and productive way to deliver as comprehensive vaccination as possible.
Richard, thank you very much. There's 2 points of influencing there outside of our system, and then also the review of primary care information and intelligence coming out of the staff survey. I'm just going to go to Becky, and then I'll ask colleagues here to respond. Becky.
Carrying on the primary care theme, Becky Malby, non-executive member. A couple of things. One is that it just would be really helpful if we pulled together what we are saying about primary care across all our reports today. So I thought it was really helpful, Brenda, when you were talking about how important it was to invest in leadership for acute trusts. I think it's equally important for us to invest in leadership for our primary care organisations, which are becoming more and more complex. So I don't know, maybe something for the fuller board, but also maybe something for us to consider. Where on earth would we get the support capacity and capability to do that? So that's the first thing. The second thing was around Richard Medding's visit. So number 7, thank you, colleagues. I'm sorry I wasn't there, but so glad you got the points that we make all the time here at the board about a flat offer isn't fair. So I see that you did raise that with him, that patient satisfaction is not correlated to appointments. Patient satisfaction is correlated to needs being met, continuity, types of appointments, but certainly not another lane on the motorway, masses of appointments. So it'd be really helpful to see, how does he receive that? So you said it, but it'd be good to say, what does he say? And the third thing was just a point of clarification, which is you've said that we've got an improvement in GP uptake for the National Improvement Programme. It was only 6% last time you told us, Ian. So it'd be good to know, how big an improvement have we got? Thank you very much.
So colleagues, who'd like to respond? We've got a few themes there on primary care, points of influencing, leadership development, as well as improvement. Rob, and then we'll come to Ian.
I just wondered if Robin wanted to comment on the local government finances. There was an additional amount of money made available very late in the day. I don't think we can claim any credit for that, but it might be worth just testing that view.
Well, I guess there are two things. There was the very late 500 million nationally made available for social care, which has made a slight helpful, and we welcome that, but a modest contribution to offsetting sort of systemic deficits that we have, that we're obviously trying to manage through different ways. And there were 19 local authorities given exceptional financial support, of which Bradford is one. It's really important to say, I think that's 80 million in this financial year and 140 million next year. That's not money. That's not money. That's just an ability. Well, it's an ability to borrow for the next 20 years the money that you don't achieve through selling all your assets. And you may have seen that Bradford's begun the process of selling assets. And I mean, we're all in that space, Kirklees and Calderdale, we're all in that space. But so the money that's received through that one-off sell your assets, the gap can then be met by a capitalisation direction, which means that you can set a balanced legal budget. So it's a very difficult, challenging position still.
Thank you, Robin. Shall I hand over to Ian then? You've got a number of points on primary care there, Ian.
Yeah, thank you. Yeah, so we are analysing the staff survey results for primary care, and we'll find an appropriate way to share those. I think, we've spoken a lot about the primary care information that we have in the board report, and this is really useful intelligence, isn't it, to bring this kind of information in. So we'll look at that. I think in terms of the Richard Medding's conversation, Becky, it was a really positive conversation. I think there's absolute recognition of the particularly contractual issues and capital and estates issues were two things that came across really strongly, and I think there was an appetite to look at those things while recognising the point in the political cycle that we're in, as well as the financial challenge that we're in. So it didn't feel like it was us saying, here's a bunch of great ideas, and it was the shut us up. It felt like a constructive conversation, recognising constraints, I would say. On the improvement from 6%, yeah, good point. I don't know what the number is, but I can find out for you. And I wouldn't mind taking your point around the sort of what the equivalent for the WIAT leadership development offer is. We've done a lot of work as an ICB to support staff within the ICB and across the wider ICS around development opportunities through, for example, the fellowship programme. But I don't think we've done anything specific for primary care. We do have a primary care workforce subgroup, which would be the place to take it. So maybe it's just having a conversation there in terms of whether there's anything we can, pinch with pride from Wyatt. Kate, I don't know if there's anything that you're aware of in that space.
Well, I was conscious that Brendan mentioned it earlier on in the presentation that the Wyatt offer for this year, you've just selected the next cohort of people, which is an increase. And it has been opened out to both the Community Collaborative and to the Mental Health Collaborative. I absolutely accept that's not huge numbers, of course, but that is an absolute start. And I think there is something in around either replicating or looking to see what's the opportunity to really strengthen the primary care offer there, which I think the Primary Care Workforce Steering Group would be the right place to start that conversation.
Thank you. Okay. We know, and this usually is something that comes out of all our board meetings, is a thanks to a certain group of health and care staff or our broad partnership, which we can take up on Richard's recommendation. Rob, did you want to come in?
Yeah, I think just keep reiterating our thanks to general practice and broader primary care for all the work that goes on. Vast majority of people seen on the same, seen face to face. Substantial proportion of people seen on the same day, more people seen than prior to the pandemic, very responsive to everything that it's asked to do. I think the question about whether risks to general practice from the fiscal environment and the political environment are adequately reflected in our BAF and risk register is something we should talk about when we get to that on the agenda, because those risks are real, I think. I think there was a question also about innovation and improvement and readiness for those things, so we can pick that up as well if you like.
Yeah, if you would. Yeah.
I don't know, James might want to come in here as well as the person who chairs the digital board. We've got, it seems to me, opportunities to think very differently about the way that care is delivered. And for many years we've talked about how do we support people to have their own information to look after themselves in a more structured way, because look after themselves anyway for quite a lot of the time, people with long-term conditions or multiple long-term conditions. So how do we improve that? And technology will help, and having an inclusive approach to improvement in technology will also help. And we've got local organisations with national reach here in West Yorkshire who are experts in that. And we need to put all of that together into our digital strategy and with any additional resources that are being made available. We know that national budgets for digital technology have been reduced in this financial year to pay for other pressures around pay, for example. So some of those investments may have been delayed. We are in the process of changing our model of delivery around digital, and we have a CDIO recruitment to conclude, which will help with the leadership of that. And then in the new operating model, we also want to make sure that the strengths that we have around our digital board, our digital networks and our innovation and improvement networks are coordinated with our research networks, and James is leading all of that work.
Yes, so in terms of response to your question, I think we are, as a system, we're in a very strong position. I think it's a great opportunity in terms of what we've heard, in terms of the budget, in terms of, and obviously there will be strings attached and we'll see what comes from that. But actually as a system, I think there's great opportunity. I think echoing what Rob has said, it's about ensuring we're ready for the future. It's about ensuring that where does prevention come into this, and how we utilise our innovation in terms of prevention. We've heard that earlier there. I think we heard earlier, especially with the Wyatt, in terms of research and development. There's very strong research and development across our system there. It's bringing our assets within our universities, and we're doing a lot of work around that in terms of how we kind of focus actually our 10 big ambitions as a system, how we ensure actually the research and development is helping develop what we need to know so that we can then have the great innovation as a health tech region. we're kind of way up there, and so there's great opportunity there. And then it's about utilising the organisations and our communities to deliver that. And so, again, echoing what Rob has said about inclusiveness, a lot of work has recently been done in terms of how do we involve our communities in both that research and that innovation, because fundamentally, if we're looking to deliver a lot of our care in our communities, in people's houses, people's homes, we've got to be there. We've got to understand what it means to those individuals who are receiving the care, and to our earlier discussions about people who are caring for those people there, and the impact that changes and innovation have for them as well. So yes, I think we're in a strong position. Yes, there's clearly more to be done. There's more about kind of joining up, and it's about across both our stakeholders, our different sectors, and getting feedback from that. But also, I think in terms of where we are, we're in a strong position. It's a great opportunity. Thank you.
Thank you. Fatima, very briefly, if you want to come in.
In the vein of great opportunity, obviously West Yorkshire was named one of the latest investment zones in the autumn statement, with a real focus on health, innovation and technology. So there's a really great opportunity there for us to join up the dots too with the joint role and see what more we can do to make West Yorkshire the place to be.
Thank you very much. Jane, to answer your other question, we didn't get any media coverage on our statement, but it was very much supported by chairs of health and wellbeing boards within local authorities and particularly at their request. Is there anything else you want to follow up on?
Can I just come back on James? I was just wondering if at some point at the board we could see a sort of digital strategy. I don't think we've seen that yet, or in terms of what our top priorities are going to be from the work that's going on there. Have I missed it? Is everybody looking at the same?
I'm looking at the chair of our transformation committee, who is nodding at me.
Yeah, we'll do that.
It'd be good to see it here rather than simply in the work of the board.
So I think if we can ask transformation committee and working with James to look at that in more detail and then come as a summary. Yep. Great. I'm conscious of time for us all, but thank you very much. Just on the point on NHS England Chair's visit, it was so good he's coming back, which is great, so we can ask him what he thought. And we've got that summary, and we have invited the fuller delivery board and a breadth of primary care, including those who joined that NHS England Chair visit and round table in February, to come back and report to us on the 18th of June. And we also note that we have got further delegated commissioning coming in from April 2025 to have oversight as a board. I'm going to conclude the report there, but thank you to colleagues on my left here for preparing that and providing a variety of detail there. What you also have is the report to the Partnership Board on the 5th of March as well, to complement how we're working on our 10 big ambitions as a partnership. Okay. We're slightly behind. I'm going to move us on now to our board assurance framework, our action plan, and this is to receive for assurance. Laura, I'll hand over to you.
Thank you. I'll keep it brief. So the BAF, the Board Assurance Framework, continues to evolve, as you'll see from the report on today's agenda, and we're sharing it really today, an initial draft of the overarching action plan, which will sit in front of the framework and aims to identify smart actions for every gap in control or assurance that we have. It is very much a work in progress, so the actions are not all smart yet. We need to keep working on those, and there's a lot of work happening. And to be fair, it's accurate as of a week ago, and I know it's already changed quite a lot this week. So it's important that we share it with you. We are hoping now to move to the routine cycle with the board assurance framework that we set in our overarching risk management framework, which is that you will see the full framework every 6 months, and that in the interim you will see the action plan, so that you can keep an eye on those actions to close the gaps. And that will be supported by all the reporting that goes into other committees. So it goes into Quality Committee, Finance, Investment Reforms, Transformation, also goes to Audit in terms of assurance around the process. So there's lots of work with the BAF. It's not just a document, it's very much a tool to drive what we do as a board, and also the work plans of our committees for the next 12 months. So I think that was all I wanted to say by way of introduction. Thank you. I'm happy to take any comments.
Okay, I think we note it's work in progress, so I'm encouraging people not to get into the detail of it at all, because it will develop and change. Jane, did you want to come in?
Yeah, I wasn't going to get into the details, so but I do. I guess a request in terms of the format. I think a few of us have found the format not that easy to actually get to the gist of actually what this list of actions, how they sort of mitigate against gaps, etc. So, since it is work in progress, if we could have a conversation offline or through Audit Committee around tweaking the format, maybe that might help it be a bit more you know, easy to understand from board members as well as the public. I think that'll be really helpful.
Yep.
Yeah, that's fine. We're happy to continue developing it.
Great. Thank you, Jane. That's really helpful. Becky?
And just to run the SMART objectives through the SMART process, because they're not awfully smart. Thank you.
Another piece of feedback for you there.
Yeah, and I think it's really helpful because there's lots of risk owners sat around the table who are hearing that feedback, so that's really helpful. Thank you.
Okay, noted, whoever you are around the table. Okay, thank you, Laura, for this, because what you're doing is bringing it alive for us as well, which I really appreciate. And I know when I was deputising for AC for the Finance, Performance and Investment Committee, this was something you were really encouraging a West Yorkshire ICB committee to do, and look at the BAF and inform the work plan for the next 12 months. So thank you for doing that. AC, did you want to come in?
Just a quick suggestion. I think I was looking at the Merseyside so one of the things I think that was successfully done there, it feels like the right thing to do, but have a look in terms of categorizing that as best as possible against the ICBs and ICS strategic objectives. So that mapping would be useful to sort of bring forward more.
I agree, and I think this is where you're seeing an extract of the overarching action plan. If you look at the whole BAF, which I obviously haven't shared on today's agenda, they're absolutely linked to those strategic objectives. So it's just in terms of the way that we share some of the information, isn't it? We'll take that on board. Thank you.
Okay, so true SMART objectives, accessible for board members and the members of the public, and referencing back to our strategic aims. And AC, you're always someone who encourages us to look at what other ICBs are doing, integrated care boards, so thank you for that. And it's, as we heard from our colleagues in Wyatt, it's absolutely happy to pinch with pride and look at other best practice, so thank you. Okay, Laura, thank you for continuing work on that, we appreciate that. So we take that as assurance. I'm going to move us on now to our system performance report. You have a lot of information there. We're going to hear from Deborah, Jonathan and Laura. I haven't lost that risk, Richard, that you've raised with us as well, that we can then bring into the corporate risk register later. But Deborah, over to you. Welcome to the meeting. It's your annual visit to come to the board. Would you introduce yourself and give us an overview of the report briefly?
Okay. Good afternoon, everybody. I'm Deborah Taylor-Tate and I'm Head of Planning and Performance for the ICB, and I'm here today deputising for Anthony Keeley. So I'm just going to go through, there was quite a few discussions last time Anthony said he was here, and I've got a bit of an update on some of the work that we're doing, and I know, Becky, that you met with Anthony and Lou to discuss some of that, so hopefully I can answer some of those questions. Maybe not all of them, so we can have some further conversations. So I think following the meeting, we've put in an executive slide with some of the key indicators. I think there's further work that we want to do with that, so any comments on that, whether they're today or whether you want to feed them back to us, would be really, really helpful. And along with that, I know people wanted a little bit more detail of what was happening in each of the places. So we're working through that. There is the next slide in there will give you a little bit of an indication, but I think there's further work that we need to do that to understand whether that's an improvement and some work that's going on to slightly improve that as well. I think there is a bit of a question is when we look at the place, the detail within the place, that will be something that we probably won't bring to the board and we'll take to the Finance, Investment and Performance Committee, so there's a little bit more detail about what's happening in all of the places. So just a couple of things which we would invite some comments back on from today. Also looking at primary care, and I know it's been a discussion, I think I talked about it on my annual visit last year about the primary care data. So we are looking at those data sources to look at those comparisons across primary care, but we know that most of that data actually sits in place, actually sits right down into the practices and the PCNs. So we are working with the place leads, the planning leads, the performance leads and the primary care leads in each of places, looking how we can start to develop that so it can really bring together some really live data and look at what's happening across the primary care. Another area that there was quite a lot of discussion, I've got it down here as slide 53, which is about the children and young people's access, the one contacts. I think it's really important that we highlight that although this looks extremely positive, as we are overachieving our target, we're overachieving our plan and our trajectories, but it also highlights that there's significant demand in this area that is much over expected levels and is putting incredible pressure on these services. And I think these are reviewed at the, I'm going to have to say it, the Finance, Investment and Performance Committee and the Mental Health Partnership Board. And I think there's further discussions going on there on how we can support that. And the last area that I just wanted to pick up that was discussed last time was around the Leeds York Partnership Foundation Trust staff turnover. And I think there's a piece of work going on there about the discrepancy of what the data is actually telling us. And there's a technical piece of work going on to understand what data sets they're using and what that's actually telling us. So hopefully over the next couple of months we'll be able to understand exactly what that is. I don't know, I'm just going to ask Keir if there's anything else you want to add to that. So we had a quick brief conversation.
Yeah, it's very on the turnover stuff. It's very much trying to understand the data. At the minute, there's a belief that that isn't accurate rather than it's a problem. So
brilliant. Thank you. It's a very lengthy report. There's a couple of areas that I do want to pick up on. That's cancer, A&E performance, ambulance handovers, category response times, electives, and the early intervention into psychosis. I'm just going to run through a little bit about each of those. The delivery of the 85% threshold for cancer 62-day target, we aren't going to achieve that this year for 23-24, but we are currently performing better than the national and the regional average, and our performance at the moment is 66.6. So though we're not actually going to achieve the target that's been set out, we are performing in one of the higher ICBs nationally and regionally. Our A&E performance target, and I'm sure many of you are aware, because I think many of you have had to hold meetings around our 76 achievement of the A&E target. In December, we were achieving 70.8%. There has been an immense amount of work, which I'll probably pick up quite a bit more when I do the winter update, around the work that we are doing to improve that for the year end. And there's massive focus for NHS England on us achieving 76%. Currently, we are achieving around 74%. The work that the trusts are doing is really starting to see some fruition, and the Wyatt, West Yorkshire Association of Acute Trusts, Urgent and Emergency Care Recovery Group are picking all of the actions around that. And I think what's coming out of that is an immense amount of sharing of good practice. So I think that's been really positive, and we're starting to see some real fruition coming out of that. Ambulance handover is always a tricky area for us. So across YAS at the moment, our category 1 mean for January was 8 minutes and 13 seconds against a target of 7 minutes, and our category 2 mean was 34.31 seconds, and that's against obviously the 18-minute target. Most of the priority and the work that is going on is around that category 2, and specifically focused on their recruitment and retention is a huge priority for YAS, and also obviously around their planning and transformation and focusing on how they can work to improve that around handovers. And I think one thing that's really important when we talk about YAS is it's not just about YAS. This is about how we support YAS and the system, and how we are developing, you know, our alternative pathways, how we're working with our community services, how we're working with our urgent treatment centres. So I think we do sometimes just jump to YAS, and we've got to think it's got to be a system response, because they can't achieve it on their own. Moving on to electives, we've made great progress. So in December, we had 253 people waiting over 78 weeks, and our current forecasted position for the end of March will be 1 person, and that's due to patient choice. So huge strides in achieving and reducing those waiting lists for 78 weeks. And the last one I want to mention is around the early intervention in psychosis, and this is particularly within Leeds, where we've seen a sustained high levels of demand and workforce challenges, and this has led to a significant drop in performance for Leeds. The target's 60%, and the performance in December was 16.7%. I caught Kia downstairs, which was very fortuitous. There is a action plan in place working across the collaborative, and obviously with Leeds and LYPFT and NHS England, and the regional head of mental health for NHS England is supporting Leeds in developing an improvement for that programme. So I think they're the main areas that I wanted to pick up. Happy to take any questions.
Okay, thank you very much. I can see people starting to put their hands up. Karen, then Becky. I want to make sure we hear from everybody, and I'm asking everyone to be brief because we've only got an hour and a bit left of this meeting, hour and a half. So, Ian, did you want to come back in and respond? Then I'm going to go to Jonathan, then Laura, and then we'll start taking comments and questions, beginning with Karen, then Becky, then Tim. Ian.
Yeah, just to be really brief, and it's just on the primary care data point. We've also joined a group that's been led by the NHS Confederation around the art of the possible and what would be meaningful metrics on primary care data. I think it's recognised as a national issue across ICBs up and down the country, Becky, and we're keen to do what we can to contribute to those conversations and get what we can from them.
Okay, thank you. You may have overheard Laura and I then talking about the order of people coming in. Sorry for not turning my mic off. Jonathan, can we come to you next in terms of finance? Then we're going to go to Laura on corporate risk register. Then we're going to go to board members on comments and questions. And please be brief.
Okay, thanks, Chair. So this is the position to month 10 for the ICS. So I'll keep it fairly brief. What you can see in the report is that at month 10 we were forecasting system balance. There were some variances in each of the 11 organisations across West Yorkshire, but overall system balance. That was subject to resolution of receiving some NHS England support for industrial action costs that had been experienced in December and January, which did come to fruition. Whilst it's not in the paper, the month 11 position is a very similar picture, so continue to forecast system balance. I think because of that, I can say with some confidence that subject to any issues coming out as part of month 12 or through external audit, that we should deliver our overall control total for 23-24, which is really positive. And I'll probably sort of echo Rob's thanks to organisations for the sort of effort, focus, deliberations, difficult decisions that have gone into to delivering that. Supported by the way that we work around mutual accountability, peer support and trust and respect. So that feels a good place to end the year in some ways. We do have another paper later on the agenda which sets out a little bit more about how that position appears in each of our 11 statutory organisations across the NHS. The other three bits I just want to draw the board's attention to is around the mental health investment standard, which remains a commitment for the board. We continue to forecast delivering and achieving our objective of spending what we need to spend on mental health investment standard and those services that support it in 23-24. We continue to see reductions in the overall spend across West Yorkshire on agency costs, which is a good thing. For all sorts of reasons that we've just discussed before as a board. There are some variations in performance this year, and those issues are picked up as part of the 24-25 operational financial planning round. And then the final thing to say is that the report also contains the latest position in terms of our operational capital, and as in previous years we will spend up to our value of operational capital, and if we have any slippage towards the end of the year, we will ensure it's deployed across the system. So that's all I wanted to say at this point, Chair.
Thank you, and I'm delighted to hear about the financial year result for 2023-24, particularly in our statutory duty to deliver a balanced budget in our system. Thank you, Jonathan. Thank you to so many people who've been part of that. Great, and I know we're not on the 31st of March, 1st of April yet, but thank you so much, and which we'll come on to a bit more in a moment. Laura, risk register.
Thank you. I'll just do some brief comments. Thank you. So this marks the final risk cycle of this year. There are 41 risks that are there for your consideration, of which there are 4 that are new. The details of those are set out at paragraph 3.4. Just to give you assurance that each of those was discussed in more detail at the committees prior to coming here to the board today, and you'll see that reflected in the AAA reports. There are 19 of those risks that are currently deemed to be high level, so scoring 15 or more. And of those, 1 is new, so that is risk 2406 around the number of qualified prescribing pharmacists and the national workforce transformation requirements. It was discussed in more detail at the committee, again, just to give you that assurance. I'd also want to draw your attention to 2 high-level risks that are increasing in score. So there is risk 2202 that has increased to 20, so it's increased to be a critical risk, and that relates to measures that have been taken to control expenditure by West Yorkshire councils and the impact on other place partners. And then we also have risk 2109 that's increased to 16, and that's to do with the national ambition around early stage cancer diagnosis. And I think those are the main points I was going to draw to your attention. As always, you have the common risk mapping, you have the place high-level risks and risk profile, and there's also a summary of the discussions from the committees there.
Great, thank you. And in the earlier item, we have a proposal of the 1.9% uplift to primary care being added to that as into the corporate risk register as well, and understanding the consequences of that. Okay, we've got some colleagues who want to comment and ask questions, so we'll take it in grouping. So if we take Karen, Becky, and then Tim, and then some responses, and then Jane and Fatima, and then we need to move on to make sure I can keep us all to time. So Karen, first of all.
Thank you. I just wanted to bring some assurance in from the Community Collaborative and from my colleagues in Community Services supporting some of the standards that Deb's talked about there, particularly around 76% on A&E. Around things like urgent community response, virtual ward, and all the work that's done in that space. So I just wanted to make the point it's more than one area. It's more than just the acutes. It belongs to all of us. So yeah, we're in that space helping, supporting. Thank you.
Thank you, Karen. And I know what came up at the last Finance, Performance and Investment Committee was an assessment and an evaluation of the effectiveness of virtual wards as well. So I know this is an increasing tool that we're using and want to understand how to best use it and when to use it, I suppose, which is something Anthony Keeley agreed to take away from the last committee meeting. So thank you for that. Becky.
Thank you. Thanks, Rob, for sending through, I think it was Rob, sent through examples from other ICBs about how they're doing their dashboard reporting. And Deborah, I suppose it's really great to have the summary on the front. It would be nice to have some of the things that are going well. So, Bradford District Care Trust SIAPT performance has, gone from here to here. And that's really fabulous. And it would be good to know why. So rather than just the mitigatings, it's also good to know the things that are going well. But we still don't have trends. So spots in time don't tell us anything really. So back to Airedale, as you know, from this morning, but it's at 50.7%. When I wrote to you asking about it, it was 60%. Previously, it was 49.3%. So it's not shifting. And yet we see in the mitigating things, there's all these things going on that are going to really help, but they don't seem to be helping. So the narrative doesn't help me, and the point in time doesn't help me. But also, I think I asked last time, rather than just it's one issue, are there collective issues around some places, or it could be a mixture, Karen, of a community and hospital. But we just get a bit more sophisticated. Where are the problems that we need to be cited on, and where do we take them? So is this now serious enough at Airedale that it's a systemic issue that we should be asking Bradford Place to look at, or is it something that should come to Quality Committee because it's really affecting the quality of services? I don't know from those spot points. So I think if we could follow through on trends, that would be really good. It's the same with the primary care data, patient satisfaction, we've asked that for trends. So trend data is really important. The second thing, the good stuff's important, and the second thing is people who are not getting is important. So we report on, we've hit the number of children that are able to get 1+ contacts over 12 months. I have no idea which one who can't. So for me, I'm not really that worried about what other ICBs are doing. I'm worried about what this ICB is doing. So who isn't getting is as important as who is getting. So we need to see that data too. Thank you.
Okay. Becky, I suggest we take that as a follow-up from this meeting. I know, Deborah, you talked about, we've done this before in working with Anthony, and I think then we work particularly in supporting Becky as Quality Committee Chair. And also, I've particularly asked for the benchmarking against other systems to see where we are where we are. But I think it's then building on what those narratives are alongside some of the graphs and the figures would be really helpful. Okay, thank you, Becky. Tim?
Yeah, thank you. Thanks for the report. Building a lot on what Becky's just said. I think there's some telepathy going on in the room. I do think starting to think about things like SPC and the way we present is really important. But
SPC, Tim?
Sorry, statistical process control charts. It's a presentational form of data. That was one point. But the main point, I suppose, when I look at things like the cancer 62-week target, it occurs to me, I don't know whether the 40+% of people who don't get seen in 62 days get seen in 63 days or 100 days. And there's a huge difference to the amount of risk we're carrying across our system depending on the answer to that question. And I don't know if that's being looked at, but I think it would be helpful from a quality perspective if we understood the answer to that.
Thank you, James. Maybe in a minute, if you could come back now, actually on cancer, that'd be really helpful. But Tim, I think we've got a task here, haven't we, on just finessing this further, James?
So it lies in the detail. Your question is correct in terms of we should be asking those there. I can tell you the Cancer Alliance and through the Cancer Alliance are looking at that, and I suppose because a lot of it does sit with some of our skin pathways is understanding what people are waiting. Are they waiting for a diagnosis? Are they waiting for treatment? There, what I would say is yes, we are looking at that there. There is some to give you some reassurance there. I know for the individual, that's not what they want to hear. They want to know whether they got a diagnosis. They want to know whether they got the treatment when they need treatment there. But there is reassurance that I suppose the people that we need to be seeing are being seen and are being treated. And we are looking into that. But we are so I give you some assurance behind that. The details doesn't sit here within this. But I can kind of work with the Cancer Alliance to kind of highlight some of that if you want. But there is work going on with that.
Okay, James, thank you. Jane, then Fatima.
Yeah, thanks, Cathy. So I was looking at the risk register, as I often do. And I guess I still feel a little bit as if there's masses of detail here, and it's clearly going through a lot of review, and we can evidence that by the movements, etc. But I still feel as if it's quite difficult to sort of look at it and understand whether we're doing enough on some of the risks to close the gap between the current risk scoring and the target. And there are some really significant, intended reductions. There's a lot of risks covered, so and some of them will be things that have got significant external influence versus ones that we can influence ourselves. And I just think as a board to be cited and anybody from the public who's sitting in to try and sort of know how we should feel about this, I still think we need to do more about narrative or explaining or looking at a subset at different meetings so that we can really sort of like have a discussion around it rather than simply it is, it's very data rich, but it's quite difficult to get to the nub of what we should be concerned about. Where should we be instigating thinking about, do we need to do more, etc. And I think it should be on us to sort of think about how we present it in that way. So again, more thinking about how we use it, because I'm concerned that we're not enabling ourselves to have the richest discussion that we maybe could have about it at the moment.
Jane, that's really helpful from your view as audit chair, but it complements what Becky's shared. Rob, do you want to come back on that, and then we'll go to Fatima?
Just wondered if it's worth, following Jane's comments, any of the committee chairs flagging any risks that they've been looking at that they wanted to escalate here or have concerns about.
Becky, I'm turning to you as Quality Committee Chair or Jane as Audit Chair, a particular risk that you're seeing that you might want to flag?
Just on the basis that I think committees do look at the risks that are associated with their oversight.
Thank you.
Yeah, I bring them up here. So I'm really worried about Airedale. I find it difficult to get it into a committee format and place, so that's why I'm bringing it here. So because we tend to look at issues like maternity, or we look at primary care, and we look at access. But I think we ought to be looking at some specific issues that come out of the board, actually.
I'm happy to comment. Not many of them sit at audit committee, so I can't comment on those specifics. But I can say when I look at something that's rated as a 20 and the target is a 6, the fact that there isn't something beyond a sort of list of actions that actually says how close we think this is going to get us towards the 6 or when, those ones for me, the ones with the biggest gaps are the ones that really worry me. And the reporting does say a few comments from the committees, but I don't think it's the richness, or from executive management team either. No comments apparently from them this time round. So I think we need to just each time be more challenging of the narrative part of this report that comes to us, so that it leads the conversation. We can clearly dip into other stuff if we want, but I think we've got a responsibility to lead it on.
Okay, and Rob, your point about coming through committees as well and those key themes. AC, do you want to comment? And then we'll
just
get
think
AC.
Jane's hit the nail on the head. I don't really want to talk about the process. I want to talk about how we're managing the risks.
Yeah.
And I think some of we do have some rich conversations, I think, in the committees about some of the risks. And if they're not being reflected appropriately here, then we need to make sure that they are. And if there are still, what we said, I think, was we've got a risk appetite. And if we're operating outside of the risk appetite, then committees need to say, we're a bit worried, what we're doing about it. And if we're not sufficiently assured, we need a conversation here about, do we change our appetite then, or do we stop doing something? Yeah. And I think that's, or does it become an issue rather than a risk? And we've taken that decision on at least one thing recently, haven't we?
Okay, and that can be reflected in AAA reporting as well, coming through. AC,
yeah, that's what I was going to say. Effectively, there is something concerning that should surface through the AAA report coming up to the board, linking the risk that we are referring to. And I think in general, in principle, what perhaps Jane and me were also talking about is the number of static risks that we hold. And if there are, I think if you look at the trend, there are probably about 5 risks over 5 weeks that sort of are static for a long time. So it's what we do about those. And I think in those individual committees, I think we should have a look at those. And if there is no movement, bring it up to the board perhaps, and see. There are some I think we could do something about them, but there are others which are more sort of. So we need to take a decision at the board level what we do with those.
Can I just get to the conclusion on this one? Because I think, sorry to tease it out, I know you want to move on. I do think then there is something about linking this back to the conversation we had about the public. Because in effect what we're saying is if we live with a static risk for a sustained period, then our risk appetite must have changed, but that must be acceptable to partners and the public. Or we're saying that is the position that we have adopted. That's the ultimate conclusion that we get to. And if we're saying we're operating in such a situation that we have to take more risks, or we have to do things that we don't necessarily want to do, that's ultimately where you get to.
Cathy, just as an example, I think we brought refugees and asylum seekers and the problems to the board here. We've asked it to be on the risk register. It's then part of our work plan to review it in terms of the risk and whether it's working, and then for us to report back to you about whether it's not. So I think we're getting, with the cycle that Laura's sorted out for us, I think we're getting into a proper relationship between the committees, the risks, the scrutiny, and then the reporting.
Laura.
I was going to make the point about the cycle actually. So this is absolutely critical because at the moment it just doesn't flow through. We're trying to fit too much into an 8-week window, which means that we're not able to have those rich discussions around it. So it's very processy. Absolutely would expect to see this starting to change because it will flow through better and we'll be able to make sure we're escalating appropriately and then cascading back.
Great. Okay, so that is Jane. Very briefly, Jane.
Yeah. So I just think I'm looking at paragraph section 6 in the paper. If we can ensure that section 6 is where we focus, and that's where that should be what's driving the discussion at board, and make sure that we're populating that with something that's more richer than simply a statement of this has changed or this is new, etc. I think that's where we need to go. Thank you.
So analysis, intelligence, I would say escalations coming from both ICB West Yorkshire committees and place committees as well. Okay. Thank you. That's really helpful. And thank you, Laura, for our new governance cycle. Just to say on the Becky's point on increasing number of people seeking asylum and the demand on services and the capacity to deliver, that was another briefing document that we agreed to provide out of the NHS England chair visit recently. And I think then I think it needs to come to Quality Committee, FPIC, Finance, Performance and Investment Committee, and those place committees that are reporting particular risks there in wanting to make sure that providing safe quality services. So, Ian, that's an action that we've agreed to take back. Okay, thank you for that. I invite you to take that debate and those actions into your committees that you're working on, whether they're at West Yorkshire or place level. Thank you. I'm going to move us on now.
Cathy, sorry.
Sorry, Fatima, you're on my list. Go on.
Sorry. So I was just going to say, on the basis of the performance report, which I'm not going to comment on, Deborah, you'll be pleased to hear, there's something that is really important for the public to hear and see, which is despite the financial constraints and the uptake in access and industrial action, we are delivering more than we've ever done before. And that's really important for the public to hear. So while I completely appreciate all the conversations about risk, which is important, and process, if I was watching this on a live cast, which I used to do, that's the message that I think is really important for people to hear. And I wonder whether there is an opportunity to use the current context and the upcoming financial challenges that we're all going to have to consider moving forward when we take those difficult decisions, that we use this document as a leverage to say, we've done everything we can in some really challenging circumstances, but despite that, we're going to have some really difficult conversations. And is this a document and a process we can use to facilitate that? It's a conversation to take outside, but I think we need to acknowledge it today.
Thank you. And it's factually evidence-based, which is one of our ways of working in West Yorkshire. OK. Thank you, Fatima. That's really helpful. So I'm going to move us on to the winter planning update. Deborah, I think it's very comprehensive and we did have a deep dive last time. So in a minute, if there is anything you want to highlight, and I'm just going to say we'll take it as read and then move to the next item. But is there anything to highlight?
The only thing I probably would want to highlight is around the winter review. I absolutely appreciate, Brendan, it's winter every day. I totally agree with you there. But we are planning to do a review of winter, and we want to take a slightly different approach this year. Critical that it's going to be aligned to the operational plan and the joint forward plan. We want to build a framework to do that on, so the reports that you've received throughout the winter have been built around the 4 national priority areas for NHS England, and we want to build a framework around that will also include some deep dive sessions on mental health, primary care, vaccinations, the Better Care Fund, so that we can really get under a lot more of the detail and really change the focus of how we review winter. I think it's true to say there's been a lot of learning this winter. We've learnt from various scenarios and experiences. Obviously, the industrial action has had a huge impact, but we've learnt a lot from that. And I think that's really important to take that forward. And we need to continue to focus on the well-being of our staff and the vaccination programmes that we've got. I think once we've done that review, which will probably take place over April and May, those outcomes need to support obviously that the ICB transformation direction and those initiatives to obviously then start to inform next winter. But I think we've got to take that in the context of what we've been talking about today around the financial challenges and the service challenges that we're going to have, and especially local government. And obviously a lot of the challenges that we have around winter is that interface between acute, primary and local authority as well. So I think just to give you the assurance that we've been working a lot and we need to pull it all together and review to see where we can improve it next year, but in that context.
Thank you, Deborah. And very briefly, your response when we looked at winter in terms of our focus on and deep dive last time, our colleagues in mental health said it was the worst winter ever.
They did, yes.
And how are you going to take that on board and then inform winter planning for 24-25?
I think that's where some of the discussions that have come out of that are around the deep dives. So I think we've all, for the years that I've been doing winter, we do it very similar. I think we want to have a session that's just on one on primary care, but we also want one on mental health, so we can really get underneath what's been going on in mental health, so that we can plan in a lot more detail about what we do next winter around all those different areas. It has been predominantly acute focused, because that's where it is, and that's where the assurance and the daily monitoring and everything with NHS England comes in. But I think we've got an opportunity to expand that. We've got all of the acute stuff that we've got, it's in train, we've got processes, we've now got next year to concentrate on everything else, I think. I think we'll have that really big opportunity to do that, obviously, I think. So I think we can really look at it in a slightly different way.
Okay. Deborah, thank you very much. And we know also that Together We Can, which is a public campaign, there's an evaluation of that taking place as well.
Yes.
I suppose I'm going to invite you back in June to look at winter planning, but perhaps we call it surge in demand, because Bev would say then also Easter, bank holidays, for example. So I think if you can come back and continue to tell us the story, and something, Robin, you said at our last meeting when we looked at winter planning, the key to this is planning early and planning together. So thank you to Deborah, to you, Lou, Anthony and many others who are working on this with so many colleagues around the table. Richard, briefly please, and then we're going to move on to the next item.
Yes, it's just as part of that review. I think we shouldn't be lulled by the fact that actually this year the weather wasn't as bad as it has been in previous years. So that will have a material impact on what we did and what we were able to do. Also be useful from a primary care perspective to look at the impact, because we didn't have access to the same day access appointments in the way that we did have the previous year. What impact has that had? I think it'd be useful to know. Yeah.
Thank you, Richard. I invite people around the table to work with Deborah and Anthony and Lou on this. Okay, thank you for that update. We're going to move on now to a report that I've invited, which Beverly and Debbie are going to present for us. This is something I'm very conscious that when we've been looking at performance reports and the dashboard, Bev has given us very helpful verbal updates, including our AGM actually last year as well, where we had a number of questions from the public as well around maternity services. And I also wanted to profile with you all as board members the work that Bev has been doing with many others, including with support of Becky as our non-exec champion for maternity services on going out and doing assurance visits. If you would explain to us, Bev, where the report's been, where it can go next. I know it needs to better connect with Quality Committee, for example, but thank you to you and Debbie for coming today to share this report with us. So over to you.
Thanks, Chair. Good afternoon. My name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB, and I'm also the Chair of the West Yorkshire and Harrogate Local Maternity and Neonatal System. I don't think that we will be rapid with this. I anticipate we'll take the full 15 minutes for the report. As you've said, Chair, we've talked about this previously, and everybody in the on the board and in the public probably knows about the national and public scrutiny on maternity services, which is illustrated in the slide, in the first couple of decks of the slide pack. And Brendan earlier talked about trying to be bureaucracy light. We're the absolute opposite of that, aren't we, in the LNMS? So what we're going to do is we're going to take the paper as read, and we're going to take you through the slide deck that you've all got access to as part of the pack. I'm going to hand over to Debbie Gibson, who's our senior midwife for West Yorkshire and Harrogate Local Midwifery and Neonatal System. And then I'm going to come back and give you an update on the progress of some work that's been done at Bradford Teaching Hospital, if I may. So I'll hand over to you, Debbie.
So, good afternoon. Yeah, I'm Debbie Gibson, a senior midwife for West Yorkshire and Harrogate Local Maternity and Neonatal System. So I'll just go through some key highlights, really. So the detail of all the documents, etc., are in the paper and on the slide deck. We are, the LMS was started about 5 years ago in response to better birth and safe maternity care ambitions. It was a maternity system at the time. It's now a local maternity and neonatal system. It was initially a transformation role, but it's now very much an oversight and assurance role. One of our key documents at the moment is the 3-year delivery plan, which encompasses all the previous documents as well as learning from the independent inquiries. From an oversight role perspective, there are several elements to that. There's the perinatal quality surveillance, which we do locally with trusts, as well as escalating that to the NHS regional team. We have equity and equality, and health and equality is something that runs through everything that we do. We have provided assurance for trust compliance with the Saving Babies' Lives Care Bundle version 3, and that's been a significant amount of work over the last 6 months. It's been a massive document to get through, and it's really driving forward the reduction in stillbirth and neonatal death rates and morbidity rates. So just another element to just bring up there is about the maternity incentive scheme, as well as an LMS we have provide assurance of trust compliance with those safety actions. Just moving on to our governance structure. So we have a robust governance structure within the LMS, and we have we work collaboratively with other partnership organisations across West Yorkshire and as well in the wider Yorkshire and Humber region and the North Eastern Yorkshire region. We have 4 key work streams, which are safer maternity care, personalised care, health inequalities and workforce. And within that we have lots of subgroups where all the actions are taken, and we drive forward transformation, quality and safety oversight and quality improvements. And down the side of our governance structure, we have got, it says there, the Maternity and Neonatal Voices Partnership. That's the service user voice across the system. They're integral to absolutely everything that we do. We have a really good working relationship with them, and we support them to ensure that services are co-produced and co-designed with them to meet the needs of the local service users. So the next one, we've just got, so in order to deliver this, we have a small core team of 5 full-time members with additional support from clinical leads from place, as well as some ICB support. So I just mentioned earlier about the health inequalities, run through everything we do. In order to support that, we have a health inequalities dashboard that that has been developed to help drive forward that. There were some examples in the paper and on the slides of how we've used that to drill down on local and LMNS data to find out where targeted work is required. It enables us to look at, for example, ethnicity, deprivation scores of particular metrics, and we've used it recently to help focus our early booking campaign to identify where there's been areas where women have not referred early to maternity services, and therefore worked with those communities to identify what the barriers were and tailored our campaign accordingly. So we have oversight of, as I said already, about saving babies' lives and the maternity incentive scheme. All 6 trusts within the West Yorkshire and Harrogate LMNS did declare compliance with the 10 safety actions of the maternity incentive scheme, and all 6 trusts did meet the minimum requirement for the Saving Babies' Lives care bundle that was required as part of that incentive scheme, which is a really good, strong position to be in. That's not the same picture across the country. We have now completed all the Q3 reviews for the Saving Babies' Lives, and trusts have progressed even further with that and are heading towards full compliance with their Q4 data. That's really positive to see. We have oversight of the CQC ratings with trusts, and we do provide additional support to trusts where they require it. So 3 trusts within the system did receive required improvement from their maternity inspection programme. 2 of those now have completed their action plans and are requiring limited support. And then 1 trust we do just providing support and guidance where needed to complete that action plan. It's moving forward really well. We completed LMNS assurance visits in November 23 to January 24 with all 6 trusts. These assurance visits were led by the LMNS, but they were supported by ICB leads, NHS England regional maternity team. Service users were an integral part of the team throughout that as well, and we also had peer review chief nurses and directors of midwifery at each visit as well. The focus was on safe, effective, responsive services. We didn't identify any immediate safety concerns at the reviews. And we found generally really positive staff, really committed to quality improvements and reducing health inequalities. There was a real commitment to safe and personalised care that was responsive to local data and needs of the local populations. There was good engagement with local service users. However, it was acknowledged that some places would benefit from further investment in that service user role there. There were just some recommendations in relation to environment factors and also some further utilisation of data to ensure it supports quality improvements. I mentioned earlier about our maternity and neonatal voices partnerships, and they're absolutely integral to everything that we do. We link with them regularly. We have 6 distinct MNVPs across the West Yorkshire and Harrogate footprint, and they work with us and with Trust to ensure that any quality improvements are service user driven. And they've come to our LMNS board and report the key themes to enable identification where focus work is required. And then just, some overview of the ambitions that we have. So in relation to the national ambitions and ICB ambitions for reducing mortality and morbidity rates, we do monitor that closely. Our stillbirth rate is steadily declining, which is really positive to see. Our neonatal death rate isn't declining. Every case is subject to a multidisciplinary and peer review using the National Perinatal Mortality Review tool. There's been no themes identified with any of them. There may always be some learning, but there's no particular themes. And a deep dive review has been started on that with our new clinical leads. And I think that's a quick summary of everything. I'll hand back over to Bev.
Thanks, Debbie. Excuse me. Just In relation to neonatal services, I'd like to give an update re some detailed work that was undertaken with Bradford teaching hospitals, and this was following some concerns that were raised as a result of a very public resignation of the outgoing chair, specifically around escalation of oversight into 3 historic serious incidents that had happened during COVID at Bradford Royal Infirmary. There's been a really detailed pieces of work undertaken by a multi-agency group that was set up under National Quality Board guidance in a rapid quality review and then a quality improvement group setting. The report conclusion of a desktop review that was undertaken into all of the evidence that was submitted to the Bradford Royal Infirmary Board concluded that evidence demonstrates that the same month the seriousness of a potential cluster of serious incidents affecting the neonatal unit was recognised and openly shared and reported. And throughout 2021 and later, the information was shared with members of the board, including the chair, in formal minutes of meetings. And that's a quote from the NHS report. In addition, there was a commissioning quality assurance visit that was undertaken in December of last year, and this involved the ICB, the members of the ICB, NHS Specialised Commissioning Neonatal Operational Delivery Arm, and also NHSE. And the findings on the outcome of that visit was that the Quality Commissioning Review found the neonatal services at Bradford Royal Infirmary is providing safe, high-quality care to its patients, family and service users. Apologies to people on the board and to the members of the public, but this was only made public last Thursday at Bradford Royal Infirmary's board. So they're now in the public domain. I'm going to stop there, but I'm just going to close with 2 final points and then open it up to questions. So I'm really pleased to report that nationally there's £35 million being confirmed in the budget to reinvest into maternity services, because we anticipate the scrutiny will continue. We anticipate when the Nottingham report is published, there will be, additional actions that we may have to take. This 35 million has yet to be, identified as to what's coming where, but it will include investment in the maternity and neonatal voices partnership that we welcome, 9 million for reduction in brain injuries programme, more midwives, and an increase in multi-professional training. And the last point that I want to bring to the board is, in the paper we identify risks, and whilst Debbie said there were 5 people in the LNMS for West Yorkshire and Harrogate, most of those have been either off on long-term sick or maternity leave recently. So actually there is a really tiny group of individuals that is presenting all this work and feeding both the LNMS board and also various other boards. So we've got a regional maternity improvement board, and Debbie's one of those, as is Sonia. So I just want to put on record thanks to for all the hard work that Debbie and the rest of the team are doing. So thank you. I'll open that up.
Great. Thank you very much, Bev. And before we finish up on this item, I just want to ask you when next for this report. And your point is that you're expecting another report to come through. So I'll give you a minute because you've just spoken for a while. Or do you want to come in back on that? What next?
So what we would like to do, we've got, so the LNMS sit around the system quality group. So unfortunately, because of the long-term sickness of some senior individuals, it's been sporadic over the last couple of months because there's only one Debbie. She has come when we've asked her, when we've got risks. So we'll see on the risk register that there are a number of LNMS risks. We have got some time in the diary as a group to look at those again, noting what comments have been made around risks that continue, and also what we were aiming to do, and we'll find a way of how we do that, is whether it be AAA to Quality Committee from the LNMS board, or we have a briefing paper, but it will be around the capacity to do that. But again, we've got plans into how to address that. Thank you.
Thank you, Bev, and thank you also for confirming and sharing the work that you have been doing with Bradford Teaching Hospital on their maternity and neonatal services. And if anyone's interested in looking at more detail, they can have a look at their board documents that are on their website, Bradford Teaching Hospital's website, for their board meeting on the 14th of March, which was last Thursday. So I've got some colleagues who want to come in, Rachel, Fatima, and then Becky, and then we'll pause the meeting. So Rachel, and Keir. Thank you. Rachel, to you first.
Thank you. Rachel Spencer Henshaw, Director of Public Health. Just to say thank you so much. I found the report really, really informative. And I also think, certainly from my experience in working in smoking, probably a long time ago now, but, you know, without looking at things like ethnicity and through those other lenses, you can hide a lot of those smoking prevalence rates, and it's so important. There's obviously quite a lot going on around tobacco at the moment nationally, and clearly there's a priority around sort of smoking cessation interventions, and I'm really keen that we focus that where it's needed in West Yorkshire so that we can make sure that we're tackling where we know we've got issues. This was more of a question, really. I just wondered whether we looked, as well as at when women book in with maternity service, how then they subsequently access services during their term, because I do think getting them in early is one thing, but actually making sure they've got either community or hospital-based contact regularly, I think can really directly help in terms of those stillbirth and that they know where they've got that trusted relationship, I guess. So I couldn't see it with the dashboard. I'm afraid my computer's just died. But again, it's just getting some reassurance around that would be helpful. Thank you.
Debbie, do you want to respond to that, and then we'll take our three other...
Yes, so one of the ambitions is to have continuity of carer implemented for women, and particularly targeting those women of greatest need, so those with highest deprivation levels and women of those ethnic groups that we know that don't always engage as easily. So yeah, that's absolutely some targeted work. We do have some continuity teams across West Yorkshire and Harrogate LMNS, but we have not got that many at the moment. But we're having conversations about how we expand that over the next 1 to 3 years, really. Okay.
Thank you. If we can take the next comments as a group. So Fatima, then Becky, then Keir.
So I'll start off with the first, Debbie. Hello, my name is Fatima Khansha. I'm the West Yorkshire Inclusivity Champion. I mean, the first really important message from your really comprehensive report, Beverly, is that the services are safe, our maternity services are safe, and that's a really important message that our public need to hear. I suppose my question is, as a woman from an ethnically diverse background of childbearing age, how can I help you amplify that message to people who share my heritage and are understandably really concerned because of press coverage about the national concerns and certain reports that have been in the national domain and media reports, etc., to ensure them that actually our services are safe, you can access them, and that we are doing lots of work to reach ethnically diverse communities to empower them to access the right services for them.
Okay. We'll come back on that response. Thank you, Fatima. Becky?
Yeah, that sort of teased me up nicely, thanks, Fatima. Which is that I think if you were just going to read the papers, first thing I want to say is when I was out visiting with you, the amount of expertise and concern and effort around this agenda is phenomenal. So we have really great people doing phenomenally evidence-driven, critical thinking work around this. And that, for me, is as assuring as it is looking at the papers. So I think it's probably, if we were going to do a page on the website, a little bit about who does the work would be really helpful so people can see these are really well qualified people. And that would give you some assurance. I think the second thing is, if you look at the papers, CQC is saying, you know, in most of our hospitals, apart from Leeds, we've got safety concerns, and you're saying LMNS is not, and that's probably a timing issue. But it'd be helpful to explain why, so why we think that's okay. And the third thing, I think, Beverly, is around staffing, because we know it's a national issue, and what's happened here, we've talked a lot about midwives being on maternity leave. Just how much of that is related to staffing issues and whether that's a worry. So I think there's things that we know, there's 2 or 3 things, 3 or 4 things that would be really helpful to put on our website about it, but including the expertise of the people who are looking at it. Thank you very much.
Great. So I think there's something on public messaging there about what's coming out of today's meeting, as well as generally about our services as well. Becky, thank you. I'm going to go to Keir and then ask Bev and Debbie to respond at the end. Keir.
Thanks, Cathy. Yeah, so Keir Schilliker from the Mental Health, Learning Disability and Autism Collaborative. So just wanted to say that the slides reference a bit about the inequalities as a result of mental health presentation. There's been a lot of work happening between the LMNS and the Mental Health Collaborative, and at the minute our West Yorkshire-wide maternal mental health service is mobilising and recruiting now. So this is a particular service that's aiming to support women and families with issues relating to birth trauma, fear of birth, baby loss, fertility and separation. So it's developing over the course of this year and will be fully operational, we think, by February 2025. So it's a real asset to support women and families over the next year or so.
Okay, thank you for sharing. That's great. Bev and Debbie, final responses. You've got some suggestions, support there.
Yeah, brilliant. Thank you. So I just want to make the point that continuity teams, I think that was on our risk register last year or something, we continue to work around that. We've got continuity teams in Bradford. They're focused and targeted on our high-risk population. Thanks for saying that, Fatima, that what we're seeing in these papers are maternity services are safe. In terms of your question around how we reach particular groups of individuals, is that we've got our really, really active Maternity Voices partnership, and actually coming from the MVPs as opposed to coming from what we would hope are trusted professionals, that voice is usually more powerful. We hope to focus more attention on our MVPs and collaborate more, and that one of the things that we found when we visited Airedale and the link with Bradford and how we could do that. So that is really encouraging work that we need to continue and aim to. And hopefully, if we get a bit of that 35 million, we can reinvest in some of that service. Again, Becky, thank you. There is phenomenal work. And one of the, I think I'd probably say at this board, whenever I'm in provider organisations, you see that. You see amazing work that the NHS does every single day. And it was a pleasure to be part of those neonatal peer review visits. These were targeted, these visits were after the CQC inspection. So as Debbie's just referred to, there were quite robust action plans because of the scrutiny. And I think Brendan noted earlier when he was talking about West Yorkshire Association of Acute Trusts, is that there are really robust processes in place at local organisational level that see all of these in absolute minutiae for their maternity services. So they will have individual CQC action plans to address what we found, and the peer review visits were after that, and they will continue. And then in terms of the staff, the specific question about staffing issues, I think staffing will always be a problem. A lot of our midwives are female, a lot of our midwives are of childbearing age. They're accessing their own services, which is fab. And that's, again, that was one of the things that we saw, isn't it, Debbie, when we were at the local organisations, is these women are accessing services in their own maternity services. So, that's great. We have got a full and detailed review of our risk register. I've said that, haven't I? One of the things we're looking at around the workforce, particularly midwives, is that I think I've said at this board previously, we've got a big cohort, but there's something about the retention agenda. There's also a massive piece of work that we're talking about at regional level about retention for student midwives, because we've got a really high attrition rate. That's not just West Yorkshire, that's across the region and beyond. So still massive focus on workforce. We're going to look at where we are in terms of our vacancies again, because it is a moving feast. So, Debbie, what have I missed that you'd like to add?
I think the thing, just probably more in response to Fatima's, really was saying that actually we acknowledge that the health and quality agenda is massive, and whilst it goes through everything that we do, we really feel like we're looking at actually our team staffing structure, and actually do we need someone to lead on that on their own, really, and also looking at that MNVP provision, as I talked about service user provision. There was national guidance was just released at the back end of last year, and we've been benchmarking against that to look at that what is that provision across West Yorkshire and Harrogate footprint. Is that reaching the services, the populations that we need, and how can we bring those two together to drive forward that agenda?
Thank you very much. Rob, did you want to come in?
Just very quickly. So thank you for the update on Bradford and the fact that those things are now in the public domain. So key line of inquiry on escalation of serious incidents assurance has been given, and that's closed. So board was aware, committees are aware, individuals are aware. Visit to the services has concluded they're safe and effective in delivering good care. Is there anything else that the Quality Improvement Group's doing, or has it now concluded its work?
So actually we've got a Quality Improvement Group tomorrow, and it is now chaired by NHS at regional level. There were a number of governance issues that weren't related to any specific service. It was around board governance. We anticipate that there will be an update of the action plan for board, noting that there's a new chair, and then we will, NHSE and the chair will decide, what happens with that key line of inquiry.
Thank you. And just a reminder then that if anyone wants to look at Bradford Teaching Hospital's reporting on their maternity and neonatal services, that's available on their website from their 14th of March board meeting. Okay, thank you, Debbie, Bev, and so many people that sit behind this in bringing this report to us. I feel there's a number of actions coming out. One, the connectivity with Quality Committee. I invite Place Leads to take this report and discuss it, Place Committee, as you feel appropriate. There's some work to do with our communications team as well at West Yorkshire level, as well as in Places. And something through the work that I do with chairs, for example, making sure the Director of Midwifery presents the maternity papers directly to a trust board. There's some really clear practical recommendations. So I encourage us all to have a look at the report and see where we may take that action ourselves or encourage others to do that. And I know, Kate, we talked about workforce has come up a few times, and it's something you raised with us when you spoke to us last year about needing to look at recruitment around midwives, for example. So I know there's still more to do, but I'm really grateful for the report today. Okay, we're going to pause our meeting in public now. We're going to take a 5-minute break, colleagues, and then we're going to come back for the last part of our meeting. Thank you very much for your contributions.